I'd like to try a new format where we review oral surgery literature in 60 seconds or less. So we'll do a quick synopsis, and then if you want to stick around afterwards, then we'll get into a more in-depth analysis to follow. But the quick synopsis is, we have a very interesting article. This comes from Gary Bouloux from Emory and Grady Memorial Hospital. It was published in 2013, and he looked at whether irrigating drains helped improve the clinical outcomes for patients with odontogenic infections. It was a randomized prospective study. He had 20 patients in each group, and all the patients, of course, received an IND and they removed the source of the infection, i.e. they removed the tooth. But then half the patients had a post-op drain that was irrigated with normal saline on a daily basis, and the other half of the patients still had the drain, it just wasn't irrigated. And the metric that he was looking for was length of stay. And what he found was that there was no difference in terms of length of stay between these two groups of patients. And his conclusion was irrigating drains does not have any clinical benefit over non-irrigating the same drains. So that was the quick synopsis. Now I'd like to take a deeper look at some of the data and some of the figures. And what I think you'll find is interesting is if you look really closely at the results, although in this study they did not find a statistically significant difference, it's quite possible that it was just an underpowered study, and if they just had a larger N, or if they had more patients enrolled in the study, then they could have found a difference. But we'll get into all that at the end. Before doing so, as a background, I kind of want to talk about abscesses in general and how we treat them with INDs, and what is the purpose of putting a Penrose drain in the first place. So let's back up and just talk about all of that. So an abscess is a mature collection of bacteria and pus and necrotic tissue that tends to form after 4 or 5 days. And the purpose of an IND, an incision and drainage, is to break up that abscess, to break up that collection, to allow systemic circulation in our blood supply, which carries, of course, the antibiotics along with any natural immune cells, which so that systemic circulation better penetrate where the bacteria is and where the infection is, so that our body can better fight off the infection. That's the purpose of an IND, and that's what an abscess. Now, why do we put Penrose drains? And there's nothing particular about a Penrose drain, but it's a foreign body. And the purpose of a foreign body is just to tent open the skin, because if you could imagine, we have a deep wound, and the last thing we want is the skin to close, and then you have an anaerobic environment where the bacteria can then proliferate and regrow and recollect, and all of a sudden you find yourself with an abscess that reformed and recollected, and you have to do a repeat IND. And that's the last thing we want to do, of course. So when it comes to tenting open the skin, we put some kind of foreign body to allow for continued egress, or because we know the bacteria and the purulent drainage is going to follow the path of least resistance. So we want it just to have a natural escape pathway where it can exude out and egress, and it will come, and usually we put it via a gravity-dependent mechanism so that we allowed for continued egress of this material so it doesn't recollect and reform. That's the whole purpose of an IND and a Penrose drain and abscess and everything like that. Now, why might one advocate for irrigating out the drains? Well, you can imagine if you were to leave the drains by themselves for a day or two, what the body's going to naturally do is a fibrin clot or a scab will form all around the drain. And as soon as that does, it will essentially render the drain functionless and useless, because as soon as a scab forms, you'll no longer be able to get continued egress of that purulent discharge. And if it's not coming out, well, then it's stuck inside. And the worry is if it's stuck inside, it could recollect and reform, and you'll have to do another IND like we said. So that's the theoretical advantages. Now, what is the disadvantages of irrigating out the drains? So I can tell you firsthand as a resident, no residents ever enjoy irrigating out the drains, and I was always the first one to quote this study and try to argue with my attendings, hey, look, it's not been shown to be any effective irrigating out the drains. And the disadvantages are, it's time consuming. It's uncomfortable for the patient, as you can imagine. The patient is very swollen. It tends to be, right, it's post-op day 1. The patient is tender and swollen, and you wake them up early in the morning and you irrigate them out, which hurts, and then it gets all over their clothes. So it's quite uncomfortable. It's messy. It can be uncomfortable. It can even hurt them, and it's time consuming. So for all those disadvantages, we have to make sure that there's some clinical benefit. So that's what this paper set out to do. And as we mentioned, their inclusion criteria was the patients had to have a severe odontogenic infection involving at least one facial space. It was randomized, so half the patients received a red rubber catheter and then they were irrigated daily with normal saline, and the other half of the patients received a Penrose drain and they weren't irrigated, they were just kind of monitored. And then they looked, in terms of the metrics, they looked at length of stay following surgery. That was the results. Here were these were the two groups, and I'll give the compliments of the study. The two groups were very well balanced and matched. So the similar ages, similar genders, even the facial spaces involved were pretty similar. So they both had a same number of submandibular abscesses versus they both had the similar number of buccal space and sublingual space and so on and so forth. So it was a fairly well matched two groups, two populations. One difference that they mention is that there were two patients who had HIV. And HIV, of course, is significant because that's a state of immunocompromise. And these weren't just any HIV patients. They had very low CD4 counts, a CD4 count of 5 and 325. So both patients were fairly immunocompromised, and both patients were in the non-irrigated group. So that's important because the non-irrigated group now has a disadvantage that they have more immunocompromised patients. So this would have been, let's say the patient at the conclusion of this study was there was a difference between the irrigated and non-irrigated group. We could then charge, hey, look, there's a confounding variable. The non-irrigating group had two patients with HIV, so maybe that's why they fared worse. But it turns out that this paper did not find a difference. So if anything, it doesn't hurt the paper, the fact that there were two HIV patients. It only strengthens it. So now you could say, hey, look, the non-irrigated group didn't do any worse than the irrigated group, despite the fact that they had two HIV patients in that group. So it turns out to be that this didn't hurt it, but I'm just pointing that out. And then let's finally get to the results. So what they looked for was length of stay. Now, they did do length of stay overall, but that we don't care as much because we don't necessarily care about the time it took to get to surgery because there's so many variables that could affect that. But let's focus more on the length of stay after surgery. If you look at the means, you'll notice that the irrigated drain group stayed in the hospital 2.8 days following the IND versus the non-irrigated group stayed 3.3 days. So just from that quick glance, if you look at those two means, you'll notice the irrigated group left the hospital on average half a day earlier than the non-irrigated group. So it almost looks like the irrigated group actually looked like they did better. Their clinical course was faster. Their symptoms resolved, their infection resolved, and they were discharged half a day earlier. The problem is it wasn't found to be statistically significant. And the reason for that is if you look at the 95% confidence interval, this range is so large. It's anywhere between 2.0 and 3.7, and this one is anywhere between 2.6 and 4.1. And when you have ranges that are so large and they overlap, that means it's not statistically significant. So that's my first critique of this study. My critique is it's possible that the N of 24 and 22 is just inadequate. And if they had powered the study with a greater population and they had narrowed the confidence interval, then it's quite possible that these mean differences would have stayed significant. That's my first critique. My second critique is I don't love the metric of length of stay. Because anyone who works in a hospital knows there's just so many confounding variables that affect the length of stay. And it's not like we reassess length of stay on a frequent enough basis for it to be meaningful. It's not like we're going to the patient's room at 4 o'clock and saying, are you ready to go? No, another hour. And then we reassess at 5 o'clock. Are you ready to go? No, another hour. At 6 o'clock, are you ready to go? Yeah, at 6 o'clock, fine, you're ready to go. No, that's not how it works. Anyone who works in a hospital knows we assess the patient on a daily basis or even a twice daily basis, but it's not frequent enough that it's meaningful. I would have much preferred they looked at something like a white count or a temperature, and specifically the delta in the white count and the delta in the temperature. So they would have said, hey, this is the pre-op white count, and then post-op day 1, post-op day 2, post-op day 3. And if they would have trended the delta white count versus the irrigated versus the non-irrigated, that may have been more significant. So that's my critiques of this study, but I do feel it's an important study to be familiar with. And not just because if you're a resident and you want to quote this study to try to defend your practice of being lazy and not irrigating drains, but just to be familiar with the literature, because it is an interesting question. We obviously could appreciate the theoretical benefit, but that doesn't mean every time there's a theoretical benefit, it doesn't always mean there's a clinical benefit. And it's an important thing to think about and important to prove, because ultimately we're only as good as our evidence proves. And as far as the evidence proves, we did not find a statistically significant difference in terms of irrigating out the drains. And until we have a better study that comes along and disproves that, that's our conclusion. So with that, I'll leave and I'll see you guys in the next episode.